Good morning, everybody, and welcome to our STEPS webinar with Denise Watson. For those of you that are new to Zoom, don't worry about muting yourself or turning off your video. It's already automatically done for you. We're going to start with a presentation on the different types of clubfoot and then moving on to Metatarsus Adductus. After the presentation, we're going to open up the opportunity for people to submit their questions. And if you look at the bottom of your screen, you should see a Q&A section. And that's the way for you to send questions that you have related to the webinar. If I could ask those that have already been, they have logged in, if you could send just a message to see that the Q&A section is working, that would be appreciated. Fantastic. Yes, I can see that it's working. Thank you very much, Therese and Rachel. Perfect. That is fantastic. So we can therefore start with the webinar. For those of you that have seen one of our webinars before, you know who I am. But for those that don't know me, my name is Loredana Guechwaya, and I'm the Managing Director of STEP Charity Worldwide. And I'm very pleased to introduce to you Denise Watson. Denise?
Oh, hello. Hello, I'm Denise Watson. I'm Advanced Practice Physiotherapist in Paediatric Orthopaedics, and I work at Chelsea and Westminster Hospital NHS Trust. I've worked with Clubfoot for 30 years now, so quite a lot of changes happened in the treatment, but Loredana invited me to do a webinar today, just trying to classify and talk about the different types of clubfoot, because I think it's quite confusing when you get an original diagnosis to know what your baby is actually presenting with.
Thank you, Denise. And as Denise said, today we would like to give a presentation with regards to different types of clubfoot a parent might come across, so the child is diagnosed with. The key point here is to understand that mainly with STEPS, when we talk about treatment, we talk about the idiopathic clubfoot, which Denise is going to talk about. And therefore, from a point of view of treatment, and when we talk about Ponseti for idiopathic clubfoot, and we receive a lot of questions with regards to clubfoot that is not idiopathic but is atypical, and therefore it's important for parents to understand the difference between the clubfoot that do exist and also the treatments that an health professional might go through in order to support the treatment of the child. Denise, thank you very much for your time, and over to you with the presentation.
My pleasure. So what I've tried to do with this presentation is just sort of simplify, explain some things and simplify, and use some pictures to illustrate the differences between the different types of clubfoot. So, okay, so first of all, there are different terms that might be used when your baby is diagnosed with clubfoot. Well, the most common is to be told that you've got a baby with talipes, and talipes really is a very open, generic term. It basically, from the Latin, means talus and foot, so ankle and foot. So it's really anything related to that. And so sometimes a severe clubfoot can be called a talipes, and sometimes a foot that really is going to be completely normal can be called a talipes. And so we're going to go through the different types. So the full name for clubfoot, the full medical name, is congenital talipes equina varus. So congenital means something that's present from birth. Then you have the talipes, the ankle foot bit. Equinus actually relates to the horse because the horse's hoof sits down, and then the varus means that the foot deviates towards the midline. Okay, so it describes the elements of the clubfoot deformity. A lot of medical professionals now talk about clubfoot because that makes it specific and makes them realise that it is this specific deformity. Congenital talipes equina varus, or CTEV, is quite a mouthful. Okay, so I'm going to talk a little bit about the different types. So these are the most common types. There's positional talipes, Metatarsus Adductus, then there's idiopathic clubfoot, atypical clubfoot, and secondary clubfoot. And within that secondary clubfoot, I'm including feet that have a clubfoot type deformity that has another condition is underlying it. So it's either a syndrome or another orthopaedic condition. Okay, so these are normal baby feet. You can see that they've got multiple fine creases on them. What you can see here is that the outside border, can you see my cursor, Loredana, there? The outside border,
yes, we can see it,
is straight, okay? There's no crease here on the middle side, and you've got a nice rounded heel cup. So these feet, this is a very newborn baby, literally a couple of days old, and you can see here that the feet are turning in. What I've done is I've popped the baby onto their tummy, because you can see this is probably how the baby was lying in utero, with the legs tucked right up and the feet tucked up underneath the bottom here. But if I then move the foot, I can move it completely. And when we look at the bottom of the foot, it doesn't look so different from that previous slide of the normal feet. There's no medial crease. The heel's well defined. It's nice and straight along that border. And actually, when you look at the back here, there are multiple little fine creases along the back. And this foot moves through almost full range of movement. So this is what's called a positional foot. So it looks curved in when the baby's at rest, but passively, so if you take the foot and move it, you can take it through full range. This very, very rarely requires any treatment. You might need to do a few stretches. It's sometimes helpful to do a few stretches, but there's no structural element to this problem, and it will resolve. So it's not really going to need any treatment, this sort of foot. But it looks quite severe. So I can see how a family might be quite concerned about this when the baby pops out. But it's going to get better, because you know that you've got the movement here, you've got a nice arch to that foot. That's it. That's a very normal looking foot. Excuse my photography, it's not always the best. Okay, so so this is positional talipes. There's full range of movement possible. The feet fall inwards into an inward position at rest, but the feet improve spontaneously, or very occasionally just respond to some stretching and some stimulation exercises, which I think we showed. They're available through the Steps website on a little video that we made, Loredana, aren't they?
Yes, correct.
Pick that up through the Clubfoot page. And the most important thing for the healthcare professional is that in this child, most healthcare professionals will use now a Pirani score, and that score is 0. So they don't have a structural element to that foot. Okay, so this is another variation. This is a foot with a Metatarsus Varus. Sorry, the background is very messy in this photograph because they're just lying on in my clinic, which is why I've got gloves on at the moment. And you can see in this foot that the back part of the foot is pretty normal. This heel is essentially normal. In fact, because I'm not a great photographer, you can't see, but actually the heel's down in neutral, and it's a normal heel. What you have got is this curve off at the front part of the foot, so coming off from the middle part of the foot. So the back part of the foot, the hind foot, is normal. All the deformity is in the front part of the foot, and mainly these are where these bones in this middle part of the foot here are called the metatarsals, and this is where they just veer off to the inside a little bit. So if your professional is using their Pirani scoring again, the score in the back part of the foot is going to be 0. Right? Now, this may or may not require treatment. There's no real consensus about how to treat Metatarsus Adductus. Some people treat it, some people don't treat it. There are various degrees. What I would say is that certain the adult foot and ankle specialists that I've spoken to say that they don't see this deformity in their adult practice. So that suggests that it corrects spontaneously. So it's very, very variable in terms of whether it needs treatment or not. Some centres do treat, some centres don't treat, but there isn't good evidence that it needs to be treated. That's a bit phasey back. Bit fuzzy, I know, but there's not good research on this type of foot out there. Okay, this is idiopathic clubfoot. So this is a clubfoot where there's no known cause. So idiopathic means no known cause. It's the most common group in the structural clubfoot group. We know that this foot's going to respond well to Ponseti treatment. I know that there are other treatments available for clubfoot, but Ponseti is really seen as the gold standard. And I mean, certainly my experience over 30 years of treating clubfoot is the only method that works in my hands is Ponseti. So I feel that that's why we tend to talk about Ponseti treatment. So it responds well to Ponseti treatment. And there will be, when using the Pirani score, there's going to be a score in the midfoot and in the hindfoot. So if you look at these feet, you can see they're obviously very turned in, all right? And if we look at the back of the foot, there's a deep crease behind the heel. And if you remember that normal clubfoot, the normal foot, normal baby foot, there were multiple fine creases here. You don't see that in the clubfoot. There's just this deep posterior crease. There's a medial crease here. There's a crease in the middle. The border of the foot is very curved. The outside border of the foot is very curved. And if you were looking at this foot from the side, you'd see that the heel is sitting high and doesn't come flat onto the ground. Right? So that's an idiopathic clubfoot. Everything else about this baby appears to be normal. The hips are normal, the knees are normal, the spine seems normal, all the range of movement is normal. Okay, so this is more of an atypical clubfoot. I've got a picture here of a very tiny baby and then a child who's a little bit older. Some of the features of this are that the foot tends to be small and fat. Obviously in the newborn, you're not going to get that same fatness. That's going to appear over a few weeks. There is a very deep crease, however, right the way across the sole of the foot. And if we go back to the previous slide, you see that the crease is really just on the inside part of the foot. It doesn't extend right the way across, as opposed to this crease, which comes right the way across. There's a short big toe. So the big toe appears shorter than the second or third toe. And they're often very, very tight at the back. Not always, but often very tight at the back. But one of the real determining features about an atypical clubfoot is that they tend to respond slightly differently as the treatment starts. And this is the type of foot that may be prone to slipping after the second to fourth cast. And particularly this feature, this cross foot, this sort of very high arch to the foot with the crease right the way across, that may become more apparent once the casting has started. And particularly if the casts start to slip, you're going to see that coming more and more. But this foot, if I saw this foot as a newborn baby, I would know that this foot was going to respond slightly differently to the treatment, and I might need to modify my treatment a little bit as I start to bring the foot round to make sure that it's not going to slip. So this is what we call an atypical clubfoot. There's a lot that we need still to know about atypical clubfoot. They're quite difficult to treat. If you're being treated at a small centre that doesn't treat many feet and they haven't seen many atypical feet, it may be that they'll notice between the second and fourth cast that things are a little bit more difficult, and there's a lot of good communication between centres now so that they can take advice from places that are treating more frequently. So this is just another picture of a child with atypical clubfoot. And you can see this really shows that short, fat, big toe. The short, fat foot, the big toe that's much, much smaller than the other toes. And that's because there's so much tightness in the middle part of the foot here, in the underside of the foot, the cavus. So that arch of the foot is really, really tight here, which is why you've got that deep, deep crease. And you can see there's not much, the heel is incredibly high, and you've not got much heel definition here. So this foot's really difficult to cast because it will slip very easily in the cast if you don't modify the technique very slightly. Okay, so those are we've covered the idiopathic club feet. There are also club feet that are associated with other orthopaedic conditions. So you can see in this little foot, the telltale is that this little baby only has 4 toes on this foot. And this will give an indication that there's an underlying problem. In fact, when we were looking at the leg, this baby's lower leg was shorter than the other side, only had 4 toes on the foot. And so it indicates that it's a bigger problem than clubfoot. There's actually a problem in the leg rather than just in the foot. So it could be that they have more toes or less toes. More common to see a child with less toes. They may be short in the lower leg, or they may be short in both the upper and lower leg. So these are called limb deficiencies. This is where the whole limb is affected. Or there may be a spinal abnormality that is not to do with the less toes, but is creating a foot that looks like a clubfoot. And in a child like this, you'd definitely be looking to see whether there were other joint contractures. So other joints that are tight. Maybe they've got elbow or wrist or knee contractures or dislocated hips. You'd be looking for other contractures. So it would show you that there was another underlying orthopedic condition which was giving a clubfoot that is a secondary type of clubfoot. And these again respond slightly differently to treatment. They can be treated using Ponseti method, but you have to be aware that they may not have the same result. They may be more tricky to treat, and they may need a different approach. This is a child with a syndromic clubfoot. So this is where there's a underlying genetic problem. And again, you can see that these are very different sort of feet. They're much more, in this case, they're more glossy. These toes are very, very flexed. If I just scoot back to show you the idiopathic clubfoot again, I think you can then see the difference in those toes. So the toes are very flexed. Everything's a little bit more glossy. So you don't have, in this foot, you're not seeing really, really deep posterior creases. The medial crease is a little bit less defined. These are very, very stiff feet. So I've put here, so they're very stiff, really don't get much movement. If you were scoring them using the Pirani score, because there aren't the deep creases, they may not actually give you a score of 6 bilaterally. But yeah, these are very, very difficult feet to treat because they're stiff. They don't respond in quite the same way to Ponseti treatment. They need to be treated very slow and carefully, but they are still worth treating using Ponseti because you may get a good correction. So they're very stiff. They have different creases. They might have more creases or less creases. There are multiple possible conditions, and it's not always possible to diagnose these at birth. And I have seen some feet where I've suspected right at the get-go that this is not an idiopathic clubfoot, and I've then referred into a paediatrician or a paediatric neurologist. It takes months and sometimes years to get a true diagnosis, and a geneticist. It might take months or years to get a diagnosis, but as long as you're recognising that they are slightly different type of feet, still okay to treat. You just need to respond to the way the foot responds a little differently to the casting. So they may respond differently to Ponseti treatment. And I think certainly with feet like this, I would say to the parents, we'll start the treatment, we'll see how we'll get on. It may not be possible to completely correct these feet, but let's see how we get on. That's a very different scenario from these feet, where we pretty much know we can get these corrected, just using Ponseti method. Okay. So these are some feet that actually presented. I think it took 2 or 3 years to really get a diagnosis on these feet, but you can see on the underlying condition of this child, but you can see the feet look very, very different right from the word go. So we always spoke to the parents about the fact that it was going to be a slightly different journey. In fact, these feet turned out not to have active muscle that pulls the foot up. That's not going to be apparent when they're a tiny baby and the foot's fixed in this deformity. That's something that's going to come on with time, and is going to become much more apparent as the child starts to pull to stand and walk. So you can't always answer those questions straight from the offset, but you can say these are not idiopathic. These are probably not idiopathic club feet, and you can get the referrals to paediatricians or neurologists. So pretty standard idiopathic clubfoot. This is more of an atypical clubfoot in a very newborn baby. And this is more of the appearance of a secondary or syndromic clubfoot. However, in the secondary syndromic group, there's a huge variation. So I'm just giving you an example of how feet can look different, but there is a huge, huge variation in that group in how the feet look. Basically, if they're not looking a bit like this or a bit like this, they're probably in this group. Okay, Loredana.
Thank you very much, Denise. That was a very insightful presentation of the various types of clubfoot. I'd like to open up now the sections where attendees can ask questions. We have received already several via emails, and for those of you that are logging in via phone, you can send your questions to info@steps-charity.org.uk. I guess talking about a syndromic clubfoot, we have a question related to autism, whether you would classify a child that has autism to have then a syndromic clubfoot.
I think that's a really interesting question, actually. We do know, and there have been a couple of papers quite in the last year or so, suggesting that there's a higher rate of autism in the clubfoot population than we thought. I don't think I would say that they're more difficult to treat in the baby section. I think the problem, I don't think I would class them as syndromic clubfoot, actually, because structurally, I don't think they fall into that group. I think the problem with children with severe autism and clubfoot is management later on in things like the boots and bar, in keeping casts on, in that side of things. So my experience of treating children with autism has been that the baby stage is baby casting is not a difficult stage, that the difficult stage come later in terms of maybe foot abduction brace management or that sort of thing. And sensory, very much sensory problems related to walking because the 2 feet feel a bit different or they're not enjoying foot abduction brace.
And would you therefore suggest that, I guess the question that came from the parent is, if you look at the normal outcome or treatment pathway for synthetic treatment, you would say for a child as autism, it might not follow the same standards. You might have to extend it for example, wearing the braces for longer. Or
I think it's such a variable group, and I think it's an area where it'd be really fascinating to do some more research, actually, because and a lot of children with autism get diagnosed a lot later. So you've got to go back and then look at, that's a study waiting to be done. But I think, and it's so variable, so variable depending on the child.
Thank you, Denise. Yeah, I agree with you. Research needs to be done to understand how to. I know pressure on us as a charity to do it, indeed. Question that has come in is, what is the percentage of children born with atypical clubfoot?
Okay, so this is a really difficult question because one of the definitions of atypical clubfoot is it's a foot that responds slightly differently to treatment. So we know that there's the incidence of clubfoot is quoted as 1 in 1,000, but within that, that's not really broken down into whether that's idiopathic, atypical, or syndromic, right? That's just a general number. So actually, there does need to be more research. Atypical is really tricky because some children, the atypical features become much more pronounced during the casting. And it's not necessarily clear on the first assessment that the foot is atypical. Does that make sense? So you don't really, there is actually debate about whether it really is a diagnosis, whether these feet are born or that's something that happens because they respond slightly differently to casting and are more likely to get cast slips. So there isn't really an incident rate for atypical clubfoot.
Thank you, Denise. And with regards to understanding ultrasound level, so 20-week scan or 32-week scan, what type of clubfoot a child might have?
So
is that possible?
No, you just can't tell. So I've seen children I've seen where they've been told that they've got a severe structural clubfoot, they come out and they've got a positional clubfoot. Other children that they haven't been able to even see that there's a deformity and they have a severe clubfoot. But really a lot, I think, depends on the position of the baby. Because you can't actually move the foot physically, you just can't tell how severe it is. You just can't tell on that scan. Now, if it's a syndromic clubfoot or something like spina bifida, and they've been able to see on the scan that there is another anomaly, then that would suggest that the clubfoot is going to be slightly more severe. But only it would suggest it because there are other features, not because they're able to tell that from the foot. So no, you can't tell from the foot. And actually, what I say to new families coming is, doesn't really, if you do the Ponseti method right, whether it's a severe clubfoot or a mild clubfoot, you should still be a idiopathic clubfoot, you should still be able to get it corrected. So it's not, as a healthcare professional, it's not something I worry about.
Indeed. And I think probably the one of the key questions a lot of parents have is the difference between positional talipes and idiopathic or positional clubfoot, idiopathic clubfoot, and that sometimes there is a diagnosis that is positional and then it turns out to be idiopathic clubfoot. So the question that we've been asked is, how long do you treat a positional clubfoot for? When do you feel that is the right time to say, well, probably this is idiopathic clubfoot?
Well, I would do a Pirani score. And if the Pirani score is 0, it's a positional clubfoot, and then therefore it really won't need treatment. If there is a Pirani score of even 0.5 or 1, that's a suggestion there is an element of structural clubfoot, and therefore I'd be much more likely to treat. So I'd use my assessment and my scoring to determine my treatment. So actually, in my head, there is a really big difference between positional clubfoot and structural clubfoot, even mild structural clubfoot, and that will then influence. So if I had maybe a baby that had a score of 0.5, so they just had a little bit of a curve of the lateral border, I'd maybe teach some stretches on that, monitor that baby for up to a month, and then treat them if it's not resolving.
Thank you, Denise. With regards to sorry, I've lost the questions that I had in mind now. With regards to the boots and bars, we have a questions to say any tips that we have to help increase compliance, which is obviously we know that it's puts a lot of stress on parents, and we, as a charity, we try to support as much as possible with videos and putting parents in contact with each other, with forums, with the Facebook groups.
This is a whole seminar, but okay, top tips. 1, the foot has to be fully corrected before the boots can be tolerated. So the foot must have some dorsiflexion. They must be able to be a little bit beyond 90 degrees, at least 10 degrees. Okay, so they must be fully corrected. The heel needs to be fully corrected. 2 is routine. Routine works with children beautifully. With nearly all children are better if they have a routine. So it's like brushing, children brushing their teeth. They don't want to brush their teeth, but if they know they have to do it in the morning and in the evening, they tend to be better at doing it, and therefore routine helps. 3, don't put the boots and bar on once the baby's asleep. Try and get that as part of the baby's, so that even as a young baby, you've got a routine, so like bath, boots, bottle, bed, so that the boots go on, then something nice happens with the baby, and then they go to sleep. And it's routine, so that every time they go down for a sleep, the boots and bars go on. And I think those 3 things, so feet fully corrected, routine, and the other thing is not giving in. Children cry about all sorts of things. They don't like having their nappies changed. They don't like having their teeth brushed. They certainly don't like having their hair brushed. And actually, the boots and bars are really no different. Yes, they wake up a lot in the night. Babies do wake up a lot in the night. It's not always the boots and bars' fault. So I think being sticking to your guns and being firm with them from an early stage and getting that routine going is key to me.
Thank you, Denise. Yes, but babies do cry, and sometimes it's very difficult when you have a newborn with the boots and bars to understand whether they're crying because of the boots or whether they're crying just because they're
Absolutely.
babies and
Yeah.
they do cry. But a routine is what we also try to promote, to have a good routine, which we know is difficult, but it would be difficult anyway with a newborn. Anyway,
there's good information on purple crying. If you Google purple crying, it talks about baby's cycle of crying, when they start to cry the most, and what that crying means. And that's I think some of the families that we work with have found that really useful.
Yes, indeed, to understand the crying of a baby and not necessarily associated with the boots.
Yeah.
We have a question, and then I will close the webinar because I'm conscious that we're already past 11:30. But the question is related to secondary clubfoot, which we have seen, and I believe in the case that you have shown, that was a fibular hemimelia case.
Yes.
The question is, when there are other conditions present, would you start to treat clubfoot first?
So that it really depends on the condition, Loredana. Sometimes with something like fibular hemimelia or proximal femoral focal deficiency, it's clear that the foot or the limb is not going to be a functional limb, and then you probably wouldn't start treating because you're going to think about other treatment modalities. So if you think that there's a chance of, if your team feel there's a good chance of creating a good functional foot, then yes, it might be worth trying treatment. But what's really important is to make sure that the family is informed and know that it may not be successful. I think it's not like trying to sort of brazen through and say this is definitely going to work. You don't always know. And it's actually something like a fibular hemimelia. There might be quite an abnormal ankle and foot. You can't scan the baby because they're too little, and you can't see on x-ray because the bones just don't show up on x-ray at that point. So you're sort of working from feel rather than from sight. So it's just about making sure that everybody knows that you're going to try, but it may not be successful.
Thank you, Denise. And one last question, but probably more than a question, is to reassure those that have been treated Ponseti. There is a question as to what support is out there and what advice we can give, and we talked about it before, Denise. And from our point of view, from STEPS, we believe that we have to organize a webinar specifically for those that have been treated pre-Ponseti, and bringing in specialists with regards to how it was treated and the surgery that children have gone through. And therefore, please rest assured that we are going to organize this. And I don't know if there's anything you want to add to this, Denise.
I think it's a group of patients who may have quite different problems, actually. So because the treatment modalities have changed so much from mainly a surgical approach to minimal surgical approach, actually the problems are very different. And I think that this group, pain is an overriding feature. Now that's unusual, very unusual with the Ponseti group, for that to be a feature. So I think it's something that would be tackled, would be good, very, very useful to be tackled at a different stage with maybe an adult foot and ankle surgeon who understands the surgery process.
Thank you, Denise. Thank you all for your questions today. The webinar has been recorded. Therefore, if you want to view it again, you will find it on our YouTube channel. Denise, thank you very much for your time. Much appreciated. And for those of you that still have questions, please do submit them to us via email at info@steps-charity.org.uk. And I wish you all a good weekend. Bye, and thank you.
Bye.
Bye.